Very good morning, friends. Today we are going to talk about the outpatient management of community acquired pneumonia. In the last video, we talked about pneumonia. What is this types of pneumonia, pathogenesis, features, all these things we discussed. Now we will move on to the outpatient management of pneumonia. Pneumonia is a significant problem throughout the world. It has been estimated that 7% of the world population are affected with pneumonia every year, of which 1/10 die or 4 million deaths happen, and most of them happen only in the developing countries. Coming to children, in children, I think it is considered to be a really killer disease, because every day pneumonia kills 2000 children. That means 2 children die every minute. So we have to update our knowledge on this important subject. Coming to the clinical features of pneumonia, we can broadly classify it as a respiratory symptoms, general symptoms. When the hypoxia, when the alveolar filling, that is alveoli are get filled with inflammatory exudate, when the filling increases, hypoxemia increases, and the child have progressive symptoms of dyspnea. To start with, cough, fast breathing, retractions, grunt, and when the hypoxia is severe, it may go irritability, drowsiness, all these things. Of all the symptoms, WHO, they conducted a lot of studies, then they come to a simple solution. Any child with a cough and cold, also present with fast breathing, that child should be treated as pneumonia. It's a very important observation. But respiratory rate varies depending upon the age. Sometimes it may referred as a fast breathing, in some time they may referred as a tachypnea or increased respiratory rate. Everything means the same. For example, a child in the age group of 2 months to 1 year, if it is more than 50 respiratory rate, it is fast breathing, then the child is having pneumonia. Like that, 1 to 2 years old child, 1 to 5 year old child, if the respiratory rate is more than 40, then it is considered to be having pneumonia. I think sometime before we all given importance for a chest indrawing. I think even with or without chest indrawing, the presence of fast breathing always denotes pneumonia. Then what is severe pneumonia? The same child, along with the fast breathing, having some general danger signs like not able to feed or not able to drink, with a vomiting, with lethargic, unconscious, or with noisy breathing, all these things shows severity. So any child along with the fast breathing, if have a general danger signs, then the child should be considered as a severe pneumonia. I think this classification is very simple, because no pneumonia, no need to treat, no need to give antibiotics. Whereas pneumonia child, definitely we have to treat the child as a outpatient management. That is what we are going to discuss now. Always don't omit physical examination, because even I think those days clinical medicine played a very major role. But in a crying child it may be difficult. That's the reason why we always emphasize count the respiratory rate for at least 1 full minute. Sometimes I used to count even second time also. And if the cutoff is more than particular rate for that age, then we can call it as a fast breathing. And when the pneumonia become very severe, you can get even bronchial breathing or a dull note on the side with the crackles. All these things, when the consolidation become more and more, we get. But in early pneumonias, these findings are very difficult to observe. So I still emphasize fast breathing or counting the respiratory is very, very important. And again, nutrition status is very, very important. Any child with a malnutrition should be very careful. Pneumonia is a medical emergency. You all agree with me. And it is a clinical diagnosis. I think no investigations are required for outpatient management. And even differentiating viral and bacterial pneumonia is very difficult. Even if you send investigation, it takes long time. So you have to treat very fast. And again, all pneumonias deserve antibiotics. This is addictive. So I already said it's a killer disease. We have to start antibiotics. And most of the times we use empirical therapy. And I think there are several parameters of which age plays a very, very important role, because the organisms are differ in different age groups. For example, in 0 to 3 months, in the early 2 to 3 weeks of life, it may reflect the mother's birth canal flora, vaginal flora, and child may even have Listeria monocytogenes or even GBS, that is a group B streptococcus and streptococcus pneumonia. In the age group of 3 to 5 years and above 5 years, organisms are more or less same, but in the 3 to 5 years, viruses plays a very, very important role that you have to keep in your mind. And above 5 years, streptococcus pneumonia and mycoplasma also play a very major role. And these things are all well talked in the earlier video. When child develop pneumonia, especially below 3 months, we don't treat the child as outpatiently, and because the child may die very fast without our because the child may require IV antibiotics. That's what I meant to say that. So immediately refer to the hospital for admission, and the child may be benefited with either cefatoxime or ceftriaxone along with aminoglycosides. I think among the cefatoxime or ceftriaxone, in very early weeks of life, people prefer to go for cefatoxime because ceftriaxone actually displaces the bilirubin sites from the albumin and increase hyperbilirubinemia. It causes bilirubinemia. That's the reason why tafus cefatoxime aminoglycoside combination still holds good. Coming to the other slabs, 3 months to 5 years or above 5 years, if you look at the organism, I think the organisms, in all the cadre, either in the first group or second group or third group, streptococcus pneumonia plays a major role. Actually, study shows that streptococcus pneumonia is very difficult to culture, and your culture you can get culture anywhere between 5 to 10%. But there are some good studies shows that streptococcus pneumonia amounts anywhere between 5 to 60%. And there are some studies will even go up to 50 to 60%. That's the reason why this organism is considered to be a very important one. And so we have to use a good antibiotic that covers streptococcus pneumonia, of which amoxicillin is an ideal candidate for that. Sometime before we have used penicillin, but now amoxicillin plays a very important role in the first line management. If the child is not responding, go for second line drugs like co-amoxicillin or other drugs being depicted here, supradoxine. And in the old age, particularly in the 5 years, start with amoxicillin, and if the child is not responding to the first line amoxicillin, go for adding azithromycin. Coming to the dose of amoxicillin, I think you can have a separate video on that. And for simplicity, I am telling 50 mg per kg in BD dosage or TID doses found to be an excellent drug in the management of pneumonia. I already said when the child is above 5 years, we have to add azithromycin, because of late last year also the atypical organism, particularly the mycoplasma, is increasing throughout the world, and you have to add azithromycin in the dose of 10 mg per kg 3 to 5 days. other drugs are given here. I think it's an individual. Every case differs. I am telling by and large amoxicillin. For example, a child has been recently treated with amoxicillin 2 to 3 times and all. We have to go for second line drugs. Why amoxicillin? You may ask. Amoxicillin is aminopenicillin with a very high bioavailability, and it is also bactericidal in action. Actually, it acts on the penicillin binding proteins and inhibits the transpeptidation. It covers two important organisms, namely Streptococcus pneumonia and Haemophilus influenza. Look at it also covers wide variety of gram-negative organisms. But of late, throughout the world, in some parts of the world, particularly some Asian countries, East European countries, and even some parts of the North America, the resistance, streptococcal pneumonia resistance is keep on increasing. It is because of the gene mutation. If you frequently expose the organism to antibiotics, the organism develop resistance by changing, because it go for a mutation and it want to protect yourself, so go for a mutation and it alters the binding sites. Actually, Streptococcus pneumonia doesn't produce any enzymes like a beta lactamase and all. It simply alters the penicillin binding sites and thereby developing resistance. The resistance again classified into mild, moderate, or sometimes susceptible, intermediate, high level resistant and all. Even intermediate level resistant Streptococcus pneumonia do response to your amoxicillin. High level even if the Streptococcus pneumonia have a high level resistance, no need to go for beta lactamase addition and all. You simply increase the dose of amoxicillin to 10 milligram per kg. Actually, this is I already talked about that. Sorry. And coming to that drug resistance is nicely given, this diagram. Can you see that this is a normally either a penicillin or amoxicillin will act on the penicillin binding protein. But if you keep on giving antibiotics, actually the drug resistant pneumococci develop because of the gene mutations, and it simply alter the penicillin binding proteins. Okay? Look at that, it is nicely fitting here. Here it is changed, so your amoxicillin is not going to fit here, so it may not going to act. That's the reason why people say in streptococcal pneumonia resistance, simply increase the dose of amoxicillin 90 milligram per kg TID, the child may respond to antibiotic. Coming to another organism, important organism, I already said above 5 years you have to think of mycoplasma pneumonia. I already talked about this as a separate video, and it is also one of the important cause of community acquired pneumonia. Sometimes it is called as walking pneumonia, because unlike the typical pneumonia, it starts as a URI, slowly developing syndrome, and even the symptoms are very, very mild. And actually, one thing I want to say that unlike the typical organism, mycoplasma pneumonia, it is it doesn't have any cell wall, and it have a lot of extra pulmonary complications that you have to keep in your mind. That's the reason why in older child you have to look for thoroughly CNS, skin, any rashes. All these things are all very, very important. It's a very nice diagram. Typical pneumonia, see like that, everything starts as a URI, and sometimes sore throat, fatigue, fever and all. Actually, in atypical pneumonia, the blue symptoms are more and more will be there, whereas in typical pneumonia, it is being depicted in the red, dyspnea, retractions, all these things will slowly, child may get bedridden. Whereas in atypical pneumonia, child may be walking. That's the reason why it's called as walking pneumonia. Symptoms may be very mild, but you have to treat. Again, another good slide, how to differentiate atypical pneumonia. I also want to talk about how to differentiate viral versus bacterial, because these are all very important from the clinical point of view. I already said Atypical pneumonia, the onset is very insidious. Unlike the typical pneumonia, it's a very sudden, abrupt onset. That's very, very important. I already symptoms are very mild in the atypical pneumonia, with a low-grade fever, without any chills, and with a dry cough. Whereas in typical pneumonia, symptoms are severe. Day by day, symptoms may be severe, very high fever with a chills and productive cough. I said because of the atypical organisms like a mycoplasma that doesn't have cell wall, so it also produces a multi-system problem. Progression is very slight, and the ideal antibiotic is macrolide, because macrolide acts different way. It binds to the 23S ribosomal RNA, thereby it acts on 50S ribosomal subunit. This is a very, very important action. That's the reason why macrolide, particularly azithromycin and clarithromycins, are used in the treatment of atypical pneumonia, particularly that is mycoplasma pneumonia. But you also keep something, you should have some knowledge about chlamydiophilia and legionella, and these are all relatively less common when compared to mycoplasma. Whereas in typical pneumonias, these organisms do have cell wall, so you have to use antibiotic that inhibit the cell wall synthesis. So beta-lactams is found to be a very good drug, and three common typical organisms are Streptococcus pneumonia, Haemophilus influenzae, and Staphylococcus aureus. In this connection, I do want to say, I think very simple knowledge. Sometimes you may find it's a very difficult between viral or bacterial causes. I am telling about the URI, not about the pneumonia. Still, you can attempt it. Viral always is a multi-systems are involved. See, multiple mucous membrane are involved. It's insidious. There is a leaky symptom. Child may have red eyes, rhinorrhea, hoarseness of voice, congested. All these things are all viral. So you can wait for that. Whereas bacterial, I already said, it is abrupt and sometimes localized because of that toxins. These bacterial infections get localized. I think this is only for a URI point of view. But still, sometimes you have to rule out whether child having pneumonia or viral illness. There, it helps a lot. Coming to the clues, I think even though I said fast breathing found to be a very, very important one, general examination is very, very important. See, any child, malnourished child presenting with a cellulitis, you have to think of Staphylococcus. Or any child in the young infant presenting with a conjunctivitis with the symptoms of pneumonia, think of chlamydia. I already talked about the mycoplasma. It is a slowly developing syndrome, and sometimes the child do develop some aspiration and they may go for pneumonia. You also think about the anaerobic organisms, and these are all not very useful in the outpatient management. Still, in the outpatient, if you are as inpatient management, it's very useful. History of exposure to contaminated water, and it highly suggests of Legionella. Round pneumonia, bulging pressure, everything has some clue about the organism. And if the sample shows Pseudomonas, you have to think of underlying cystic fibrosis. Lastly, before closing my talk, I want to tell about the antimicrobial resistance, bacterial resistance. I am telling bacterial resistance is keep on increasing, and because it is I can say it is a hydrogenic disease. If you do not correctly use antibiotic, then the bacterial resistance will keep on increase, and again once the bacterial resistance occurs, it will keep spreading to the other organism also. Actually, if you keep on exposing the organism to antibiotics in a not a very appropriate antibiotics, or less dose, not appropriate dose, or less duration, actually simply the bacteria develop several ways to get away from the antibiotics. It simply alter the target size, has been happened with the Streptococcus pneumonia. Even in methicillin resistant Staphylococcus, they simply changes the target sites, that is a protein binding sites. Some of the organisms produce enzymes like beta-lactam, we all know that. And once they actually the resistance, that bacterial resistance, it is not chromosomal mediated, it is mediated by the plasmid. So this resistance that present in the plasmid very easily transferred to other bacteria, either through the bacteriophages by transduction, or even the bacteria while die, they liberate the plasmid that has been scavenged by the other bacteria. That is called transformation. And sometimes binary fission cause conjugation, the plasmid simply the plasmid become double. So you have to be very careful treating antibiotics. When you decide to pen an antibiotic, kindly think we want to live the safe world. At one time the climate is a problem, the other thing is the antimicrobial resistance is a problem. So before starting an antibiotic, you have to think twice. But I don't say, but all pneumonias deserve to be treated with antibiotics. This is a very nice article I happened to go through. It appeared in 2019. 9% of the global deaths are due to antimicrobial resistance. Okay, and most of them happen in low and middle income countries. Especially children below 5 years and older people before 60 years are vulnerable. And so you have to use antimicrobial wisely. Or nowadays a lot of molecular and microbiological techniques are available, you can use. And these 6 or 7 organisms, they are called escape, are found to be very, very important in the world, namely Escherichia coli, Staphylococcus aureus, Klebsiella pneumonia, Streptococcus pneumonia, Acinetobacter baumannii, and Pseudomonas aeruginosa. These 6 leading organisms are very important. When you happen to get this organism, you have to be very careful. Thank you. And before wind up, I want to say that a good patient treats the disease, but a great physician treats the patient with the disease. Thank you. We'll meet again in some other occasion. Okay. Thank you very much. Okay, very good.